See, I was gonna watch. I guess I can watch from there. My dog socks. Mute. I hope I can stop you in the background.
All right, good morning, everybody. Welcome to the daily operational brief for Monday, December 7th, 2020.
Hey everybody, welcome to the Monday morning MDPB meeting. Folks, remember this is an extra meeting. If you don't mind, please putting yourself on mute once you enter the room. There's a lot of background noise right now. Just in the effort of trying to maintain
Friday afternoon.
If I can put you on mute if necessary. I see 1, 2, 3, 4, 5 of our MDPB members. If folks don't mind, I've noticed that our MDPB members sometimes show up a little bit late, so we'll give them a couple more minutes to get here and then start our activities. Thanks to everyone for coming.
Hey, man.
Hey.
Do you guys need any storage? I'm out of 3 of the 4 of those horizontal shelves over here.
Oh, nice.
Actually, I should be out of the 4th because I can find boxes.
Nice.
I left the box upstairs.
I found it. I used it.
Okay,
It's already home.
sweet.
All right. Let's give folks another minute or so. I'm also hopeful Sam will be able to join us today. I've been trying to reach out to him this morning. We'll see if that's possible or not. Again, as you enter the room, please mute yourself. If you're an MDPB member, feel free to unmute to talk. If you're a guest, please either use the raise your hand function or use the chat function. And we're certainly interested in hearing from everyone, but we'll just in the effort of maintaining the meeting logistics and such, please use those functions and we will get you engaged at that point in time. All right. Why don't we get going, and as other folks join us, we will include them in. Welcome everyone to an extra MDPB meeting today. This is I believe it is our first Monday of the month or second Monday of the month. The group decided to meet last time we met last Monday in an effort just to kind of keep awareness around the vaccine campaign within the state. Why don't we though start out as we have in the recent past with just check-ins from everyone and just see how folks are doing, how things are going. If there's any vaccine news from your neck of the woods, please let us know. For right now, why don't we start with Bethany?
Good morning, everybody. I just got done working the whole weekend. Census is actually down a little bit, which was strange. The ER was definitely full most of the time, but our inpatient census was down a bit. That being said, the proportion of COVID patients is up, so the ratio was a little higher than normal. So we are seeing a definite increase in the inpatient side of that. I don't have any vaccine info. We keep waiting because now we're in the Maine Health umbrella officially to hear from them about when we will be receiving vaccine, but we are planning for clinics to vaccinate our staff and whatnot. So that is definitely coming in the next couple weeks, probably before the new year. I did at some point during today, if we could talk about sublingual nitro as it applies to the whole aerosol generating procedures. I've gotten no less than 10 emails in the last 2 weeks about it. So if we could talk about it as a group, it would really help me out.
Great, yeah. Let's see, Benji, how are you?
I'm doing well, Matt. Hope everyone else is doing well. I may have to jump away at some point. There's a guy coming to look at my chimney, so he's supposed to be here at 8. So I will, if you see me disappear, that's why. But updates for me, I don't have a ton. Most of my stuff this week in terms of EMS stuff has really been focused on that interfacility transport stuff. At my hospital is becoming a bigger and bigger option as we are increasingly looking to transfer patients and are transferring patients. And so trying to figure out what sort of options we have and whether or not we need to enter into agreements with different agencies. So it's definitely a big ticket item where I am in terms of the COVID response. Otherwise, in terms of population, COVID population, we haven't seen a horrible difference from last week. It's about the same where we're seeing it, but it's not maxing us out quite yet. And I think the EMS volume is kind of corresponding. There's some more EMS traffic, but it's not overtaxing at this point. I think that's all I've got.
Great, thanks. Beth.
Hi, everybody. Good morning. I think we've seen a big difference over the last week and definitely higher COVID volumes. And it doesn't take much to overwhelm a small hospital. And when, the majority are PUIs coming in, it kind of does get a bit overwhelming. We've had inpatients. We've also been trying to ship some patients. And yes, we're having a big issue with interfacility transports also. From an EMS standpoint, I guess still surprised that I'm seeing violations of the pandemic protocol. And in fact, called out 3 services right at the moment last week for improper PPE and nebulizing PUIs. So, I guess still trying to work on that despite all the work that we've been doing for months in communicating with services and rolling these things out. To still see that has been a bit disappointing. So that's all I have.
Beth, I had a conversation with Dave last week. Not necessarily the exact same issues that he's running into in his neck of the woods, but I think the right answer is exactly what you're doing, which is strong, steady, keeping the same message works in the midst of the pandemic, and just trying to exemplify exemplify those steps ourselves as much as possible.
Yeah, thanks, Matt.
So I'm sorry that you're running into that, and let's talk offline, and if there's anything we can do, please let us know.
Thank you.
Tim.
Hey there. So we're doing, I think we have 19 inpatients with COVID as of Friday was the last report I could see. And feeling a corresponding uptick in the ED, but feeling overall steady in response. The weekend, Bohansky did a really great with Dora Ann Mills together, did a COVID update that we had online that I got to listen in on Saturday. I don't know if anyone else is hearing that. I thought it was fantastic. The combo 1-2 punch of those two was great. And I think it's recorded, so it's a good resource out there for others, and a nice place that I feel like I can point people to if they come at me looking for an update. So I really appreciate all the work Mike put into that, especially the phase 2 update and summarizing it. It was really a great thing to see, and I was furiously taking notes. I always love that, just sort of filling in little gaps around the edges for my global understanding where things are right now. So other than that, we're holding steady, but wringing our fingers like everybody else, right? Just worrying of what's coming next. But little bit of anxiety building around the ER, as far as staff and, asking us, are we going to the next level of similar to what we did in the spring? So we're going to work on messaging that and having good responses to folks. But I do feel overall we're holding steady.
Thanks for that, Tim. Seth, I think I saw you there. I don't see your face, but are you still with us?
I'm here. Can you hear me?
Yeah, we got you. Thanks.
All right. I'm driving, so that's the background noise. I'm on my way into a Monday morning urgent care shift, so super stoked. I don't know our COVID hospital-wide numbers, but I know it's been getting busier and starting to back up into the ER. Just waiting for admissions to go upstairs until afternoon, and bunch of things that we don't usually see when we're at our normal steady state. It's interesting. We're also seeing some higher acuity patients that have nothing to do with COVID. And I think this must be because bigger systems are filling up. So we've gotten some rotor wing traffic for trauma, which we never had prior to a couple weeks ago. So some changes there. We think we're using the Binex Now test at the urgent care, which is interesting. Those are the big things I have. Nothing too new to report EMS wise. I had a question for the group, just something to think about since none of us have gotten vaccinations yet. I know everybody's trying to figure out how to get a little more uptake on this, and I was curious what the group thought would be about basically filming ourselves on iPhones getting the vaccine and putting it together, maybe with a little group narrated voiceover as basically a PSA to roll out to the services, and just kind of trying to demonstrate a lead in that regard. So curious to hear what your thoughts are. That's all I've got.
Thanks for that, Seth. I heard that idea at another meeting earlier in the, actually late last week. And I think it's an interesting idea. Certainly we've heard the president, three former presidents are going to do that same type thing. My personal feeling is that if it helps engender trust in the process and in vaccination, then that would be great. But let's talk more offline about how to pull that off. Mike.
Hey guys, so clinical update for me. I know I worked a bunch with Matt and Kate overlapping this weekend, but the COVID volume is definitely up. I spent all day in a PAPR yesterday, and whereas we usually had a lot of PUIs and people we thought maybe there were a lot more definites in the unit, both based on their coming in with positive tests and having gotten sicker after having received that diagnosis, or just very clear-cut cases when we're taking a look at them clinically. So that is different compared to where we were even just a couple of weeks ago. As Tim mentioned, I got to participate in that conversation on Zoom with Dr. Mills and a bunch of providers over the weekend. We did that twice. That was great. She focused on some just general COVID updates and obviously fielded a lot of questions about vaccines and vaccine technology. I focused my stuff on the low-risk patient disposition that we previously called the phase 2 protocol, and got some good questions about that. So that went really well. As you're hearing, and as I think we're all sort of discussing here, I think our biggest thing going forward is going to be our messaging around vaccine. The timeline of that, of course, is going to be entirely out of our hands, but people are starting to ask a lot of questions. They're going to look to us for answers. And so anything we can collectively do to A, not have to reinvent the wheel individually, but B, have that message come from all of us, I think is going to be really big, and happy to do what I can with that.
Thank you for that, Mike. Kate.
I'm in the background. I don't have much more to add. Worked over the weekend, and we've been on diversion here and there, just because of lack of inpatient beds. So that's been frustrating. So the emergency department's been full of folks that are boarding. I don't have much more to say.
Kate and I are interviewing medical students for residency together. We are an interview team. So we are hanging out together for the good part of the day on Zoom or similar platforms.
Wait, they paired the two of you together? How did that happen?
Yeah, I don't know. Lucky students. They get to hear from Kate, not me. So I will reiterate clinically and from both an emergency medical services and emergency medicine standpoint that the volumes do feel different these last week. I've been working a bit the last 7 days, and I think what I'm noticing is that there are a lot more defined cases, people who know they have COVID but are hitting that second week mark and arriving very sick in an extremis with respiratory compromise. And I think we're certainly noticing that. We're noticing the impact of this from a flow standpoint, as Kate mentioned, as Mike mentioned. And I think I'm noticing the same thing reiterated in the EMS agencies that I interact with. The bulk of today, I was hoping to just, the purpose of this meeting was to keep folks abreast about activities around the vaccine. I was hoping that Sam could join us. He and I were talking over the weekend regarding some things. I don't see him on the phone or on the Zoom just yet. But let's just launch into this. I don't have too much updates. The first thing I wanted to talk about is timeline. What I know right now is that we should expect vaccine in the state probably within a matter of either days to weeks. And we should expect that first, the vaccine being offered to the first group of Tier 1A members in that same time frame. I would not be surprised if by the next time we meet, people are being offered and receiving the vaccine. What remains uncertain in my mind is whether or not we can vaccinate all of the Tier 1 group with the allocated vaccines provided to the state, and that remains to be seen how we further delineate within the Tier 1A if necessary. But I do believe that the vaccine will be here imminently or available for distribution and implementation imminently. Kate, myself, Sam, and John Martell spent some time last week working on a talking points paper. This is, if you recall, when we talked about this either last week or the week before, we talked about a multimodal approach to this. The first piece of this is really starting to create common messages for our group. And we started plotting that out last week. And as soon as we get to a finalized draft form, I'll send that to everyone. There was some still passing back and forth over the weekend when I was working clinically, and I didn't get a chance to catch up with the most recent version of that. But I'll try to get that to folks ASAP. Please know that we still don't have all of the information from either of the drug manufacturer or device manufacturers, the vaccine manufacturers, Moderna and Pfizer. We're expecting that information to be released in the process of the EUA dialogue. And rumors are that we should be able to access that. Well, rumors are that we should expect to see that sometime around the 10th. So within days, we should start seeing that. And I think that's going to be, at least in the case of Pfizer, which is the expected first EUA authorization, that will be very helpful to get more granular information on the details of their safety and efficacy work around this vaccine. That will be very helpful in building our talking points, building our clinical bulletin, et cetera. And so please know that if we send anything to folks before that release of information, that we're going to also scramble very hard once that's released to add in more information. So this will be kind of a working document. once that information from the EUAs does come live, then I think we can really start moving forward with all the rest of our work around bulletins, videos, and town halls and such. So more to come on that, absolutely. In the interim, we've been trying to meet with a bunch of folks and talk this up locally and try to reach out to local clinical experts. There have been local meetings through our health system, which Kate and I think others have attended those. Those have been really good in sort of understanding some of the background behind the vaccine. And then Kate and I have also met with some other local leaders one-on-one to kind of talk through our kind of processes, and gotten a lot of support around that. So that's kind of where we're at right now, drafting those talking points, getting them to you as soon as possible, waiting for the information dump from the EUA process, then moving on to clinical bulletins, updating the talking points before that, building out the rest of our kind of media campaign around this as well, and then hosting the town halls for us to all kind of converse around. As we get more information, I'll try to catch up with Sam later on today. If there's any other news, I'll blast it out in email form to everyone. Any questions about any of that stuff that I just mentioned?
Hey, Matt, it may be a silly question. Maybe I should have watched Mike's webinar. I apologize. But the questions I've been getting a lot of people asking me is where's the vaccine actually coming from? As in, is it going to be distributed by the state? And then who from the state is distributed? Is it our local CDCs? Does it come from the hospitals? I think you get the gist. People were just asking, how's that actually going to happen? And I did not have an answer.
So that's actually a great question, Benji. And there's a couple different answers to that. So it depends a little bit on which vaccine we're talking about. If you recall, Pfizer is the vaccine that requires ultra cold storage. So the vaccine itself will be coming from a location that has ultra cold storage. In order to gain receipt of a vaccine, you have to be authorized by the state and federal CDC. And in the context of the Pfizer vaccine, which requires ultra cold storage, it also gets shipped in pretty high numbers. Like I think the number that I was told was the shipping containers can contain anywhere between 975 doses of the vaccine all the way up to 5,000 doses of the vaccine. What we expect to happen is that any of the current vaccine distributors with ultra cold storage refrigerators, I think there are between 5 and 6 in the state right now, they can apply with the CDC to take first receipt of any of those vaccines. Then they will be distributed beyond that. So as Bethany mentioned, when she talked about these being distributed through their clinics to staff, what would happen is the vaccine comes out of ultra cold storage. It can stay in a refrigerator for up to 5 days, and then it needs to be reconstituted and used within, I believe, 6 or 8 hours. In the 3 hours, Bethany's correcting me, so thank you for that. In the case of EMS, the state has purchased or has access or already had, I can't remember what, an ultra cold storage refrigerator. And we are working with them so that they would be the point of contact for us, and we would be taking receipt of vaccine from them. There's also the possibility of local relationships between EMS agencies and hospitals that have ultra cold storage as well. In the case of the Moderna vaccine, which does not require ultra cold storage, it just requires cold storage. It's more feasible that an EMS agency that has applied through the state and federal CDC to be a vaccine distributor themselves could take receipt of that vaccine primarily. So the federal government could ship that vaccine to the EMS agency, or rather not the federal government, but Moderna could distribute that to the EMS agency directly. We know that there are other vaccines coming down the pipe. I think it's AstraZeneca maybe, and then Johnson & Johnson. Those do not require ultra cold storage either. That's a bit of a different technology. And also in those instances, the vaccine manufacturer can ship to any approved vaccine distributor. So no matter what, in order to provide the vaccine, you have to be authorized through state and federal CDC. But you also, through that process, can take receipt of the vaccine as long as you have the logistics available to do so. In the case of the Pfizer vaccine, which it looks to be the first vaccine distributed, There are a couple things you still need, including the right type of freezer / refrigerator unit. And Sam has been working with CDC, the state CDC, to help be very clear about what the required elements of that device is. Does that answer your question, Benji?
It does. Sorry, it does. I appreciate it. Thanks.
Great.
Hey,
Any other
Matt,
questions?
yeah, quick question. The tier 1A, like you talked about the first group amongst tier 1A, is tier 1A just global healthcare providers, or are they distinguishing amongst healthcare providers who is tier 1A, or even amongst above that first group?
So
Tim, you didn't get a card? I've got a card, Tim. You didn't.
So Tim, what we understand from the ACIP, which the Advisory Committee on Immunization Practices, which met a while ago to help define what these are, Maine approved or Maine agreed to use that same delineation. Tier 1A is frontline healthcare providers, residents of long-term care facilities, and the staff that support them. And so frontline healthcare providers, I think what we recognize is that there is the ability to further define that locally. And so the state has been meeting to help define what that means in the state. It does not mean that every person who has a role in healthcare would immediately be offered the vaccine in tier 1A. And what will likely have to happen is very hard conversations, both at the state and local level, about which healthcare providers, both hospital, pre-hospital, et cetera, get offered the vaccine first if there are limited numbers. In a perfect world, we get enough to vaccinate the entire tier 1A. I think we have to recognize that we've heard rumors, at least, that the number of vaccines may not be adequate for that. There might be some further delineation within the tier 1A group to help strategize and triage the vaccine distribution. But more to come on that, Tim. I think that's a moving target and predicated a bit on what our numbers look like and how that occurs. But within the frontline healthcare providers, sort of a very broad brushed approach is certainly EMS, emergency medicine, ICU, and any inpatient ward that manages COVID positive patients. Any other questions at all?
Hey, Matt, when you guys are moderately happy with it, could you send out that talking points document?
Yeah, I'll work on that either today or tomorrow and try to get you, again, it's going to be draft, but I'll get you what we've got most recently, okay?
Hey, Matt, are you wanting us not to share that in draft form once we get it? What are you looking for? Do you want to control that until you give it final, or? Yeah,
great question, Tim. If I'm happy to share this within our group, but until we get the EUA information, I think it's important to keep it within the group. And I'll work as hard as possible once we get the information out of the EUA to create a final form of that and then send it out, and we can distribute that. Remember though, this document really is kind of internally for all of us to be sharing similar messages. The information from this will be distilled into, and it's like right now 5 pages long. The information from this will be distilled into 3 other forms, which would be our clinical bulletins, whatever video we create or slide presentation we create, and our town halls. So it's probably more appropriate to share those 3 things as a group, but this is just for us internally to kind of all be kind of able to share common messages when we're approached about these questions. Does that make sense? Okay.
Matt, do these talking points discuss at all a little bit about, I guess, how things aren't really going to change after the vaccine? And what I mean is that I've been, sometimes with some of my interactions with EMS and with some of my own staff at the hospital, I've been kind of sort of almost talking it down, saying, because everyone says, well, once you get the vaccine, you're not going to wear masks anymore or anything. I'm saying, no, it's probably going to be the exact opposite of all that. And I was just hopeful that there's that you're going to address some of that. Just, I shouldn't say talking it down, but I'm not sure what the phrase is, just to say that we're still going to be masking and goggling for a good while to come, even after the vaccine, and even if the vaccine does work.
That's a great point, Benji. And that is included in there. The way that I'm kind of understanding this and the way that I'm sort of recognizing this, the metaphor that I'm kind of starting to use for myself is that we've been in a very defensive posture right now against the disease. It's important to really fortify our defensive posture in the context of this surge we're seeing. So all the things we're doing, identifying PUIs, universal droplet precautions with airborne precautions for the 3 instances that we've defined, either the positive PUI, positive COVID patient, any aerosol generating procedure, or anytime a patient can't comply with masking. All of the distancing, isolation, quarantine, return to work, all those things that we're doing, that's our defensive posture. And we really do have to fortify that right now, especially in the context of the surge that we're seeing right now. But our first opportunity for an offensive stance against the virus is with vaccination. But think about this like any other PPE, related to the pandemic or not. And another metaphor to think about is turnout gear. This is just one more piece of turnout gear, but we would never take the rest of our turnout gear off if we were given a new helmet, for instance, right? This is just a new helmet. It doesn't mean we can take off our bunker, our pants, our boots, our jacket, our gloves, our Nomex, our SCBA, anything else. This is just one more piece of turnout gear. We will get to a time when the flames are dying down enough that we can take off these things. But immediately after the vaccine releases, we will not be able to do that. We will maintain this defensive posture until we achieve adequate tamping down of the R0 within the community. But that's mentioned in there as well. Any other vaccine questions? Let's then get to Bethany's question. So Bethany, you wanted to ask a question, or you've been getting questions about sublingual nitro and aerosol generating procedures. Can you contextualize that question you've been getting?
Yeah, so since we came out with the list of aerosol generating procedures, and I'm not sure, I think there was a couple meetings where this was talked about specifically, but the nitro spray, for obvious reasons, has been considered something that should not be used in patients, especially if they're PUIs or COVID positive. That piece aside, because I'm not sure, I think if we properly decontaminated those vials or pumps, if you want to call them that, it probably would be a safe option. But a lot of services use them because of ease of use and efficacy. They work a little bit better in patients who don't have a lot of saliva going on. So switching to the tablets has become something that has been a point of contention, in that the same kind of cross-contamination could happen in a vial of the tablets, because people wearing gloves might not change their gloves and put tablets back in the bottle. And then technically, by the letter of the law, which doesn't actually technically apply to EMS, the vials should only be used 1 per patient, which then gets expensive. There are other options out there. There's a powder form, but that's as expensive as 1 vial per dose instead of 25. So I've just been getting a lot of questions about what our stance is as an MDPB, about what product they should use and whether it can be multi-use for multiple patients. As a pharmacist, I would like to say 1 bottle per patient. As an EMS provider, I say we've been doing this for a really long time, and I think that's unnecessary, but I can't come up with an official word on it without, the group helping me out on it. So I didn't know if anybody else had any thoughts or suggestions.
Well, let's tackle this kind of bit pieces. What's the group think about nitro as a potential aerosol nitro sprays as a potential aerosol generating procedure? Do we think that carries risk?
This is Tim. They're opening their mouth. They're not, I don't see any exhalation or any positive pressure having to do with that. They are unmasking, which is an increase in exposure for that to receive it. But I don't think that's on par myself, thinking it through with other aerosolizing procedures.
Is it possible to wipe down the a dispenser, delivery unit, whatever you call it? Because I mean, I can't, in the actual realistic world, I can't imagine there's some sort of droplet contamination. I mean, you know, just opening your mouth, that there's air infilling and stirring those droplets around. So I feel like from a technical standpoint, there definitely is some risk of contamination, but I'm wondering if they're easily wipe downable with like a cavi wipe or something like that.
That was posed to me in a lengthy email by one of our experienced providers. You know, wiping it down similar to what we would do for a blood pressure cuff. And I don't think that's unreasonable. What they should be doing when they administer this anyway is spray a safety shot into the air to make sure that it's firing properly anyway. So that would dislodge anything that might be in the way. But yeah, so I thought that was a reasonable option. But again, I couldn't make a group decision all by myself.
Yeah, I sort of agree with Tim's respect here of I don't consider the spray into the mouth an aerosol generating procedure. Certainly if the patient coughs or sneezes or something after you do that, it is, but they may cough or hack or something after getting a sublingual pill as well. So I think the risk is more dependent on their reaction and not the action of the spray. I don't have a whole lot of strong thoughts about the reusability of canisters, whether it's sprays or tabs. But in my personal thinking through this, because this was posed to me a little while back as well, was I did not see the spray itself as aerosol generating, such that PPE stances would need to change for one or two sublingual sprays.
Having looked at this question in as much detail as I could, and admitting that the CDC itself says that there's no comprehensive list of aerosol generating procedures, no delivery of intranasal, well, the delivery of intranasal medications itself, nor any sprays in the mouth were listed on anything I found to suggest that those would generate any aerosolized particles at all.
I mean, I can tell you in my personal practice, if I'm doing an oral exam on a patient, I'm putting an N95 on, in that I'm going to spend several seconds or minutes in and near their mouth. But doing other things where I'm briefly handing things to them, or they're briefly unmasking, I've not considered those risky encounters.
I think the tricky thing here is that traditionally we've used these dispensers, whether they be the tablets or the spray, as multi-patient use, which in the hospital letter of the law Joint Commission says is a no-no. We at MICO still occasionally, very frequently, use the tablets for multiple patients just because of the way we dispense them. But according to the Joint Commission, that is a not okay thing to do. It's mostly involving charging the patient. So if you charge per bottle, it's illegal to divide that bottle amongst multiple patients. But in EMS, we're not even touching that part. So that argument doesn't really apply in this case. So it was mostly the multi-use is what is triggering the services to get a little upset about this, because it is expensive and it's something that is frequently used. So I'm happy to put out an official word. I just wanted to see what you guys thought about the spray specifically, or the gloves on the tablets.
Bethany, what is the cost on one of those sprays? I don't know off the top of my head.
You had to ask me. I know the tablets are $650, $675 a bottle, which is 25 doses. That's if all of the tablets are usable by the time you get to the bottom of it. The sprays, I think, are maybe 3 times more that. But as I said, they're much more efficacious, and services tend to think they're a little bit easier to use because you don't have to open a bottle, pour out a bunch in your hand. Patients respond to them better. So a lot of services have decided to switch to the spray, especially those that use it more frequently. But I believe it's about $18 a bottle. So it would be a cost issue if we mandated that they use 1 per patient.
The info I got from the Southern Maine pharmacist when this question came up from a service around them was that a spray bottle cost $173. and
Rick,
that the
Rick is saying
bottle of,
130, so it is
yeah,
pretty up there.
and that the bottle of tablets was $6.76.
And like I said, there is a powder form that's out there that's unit dosed per dose, as in the 0.4 milligrams per packet, but those are $6 and change a piece. So that really isn't an option for most services either.
Well, Bethany, why don't we do this? Why don't you, if you want to draft up something and send it to me and Kate to kind of look at, and we'll send out to the group to try to gain consensus over email and go from there. Okay.
Sounds great. I appreciate everybody's help.
And if anyone has any strong feelings, please send them our way, and we will we'll build that into the bulletin.
Yeah, I think just summarizing those thoughts, like multi-use spray with a safety shot in the air before next patient, as well as wipe down after each patient. We might be able to get our heads around that as an okay. But I'd be curious to see once you write it down and think about it a little more.
Yeah. Well, folks, is there anything else people want to talk about? We are currently not scheduled to meet next week. Actually, sorry, we are scheduled to meet next week already. That's the second Monday of the month. So why don't we resume this conversation then? I'll be sending emails out to everyone between now and then. Please keep an eye out for those. And we will, if any questions or anything come up between now and next Monday, please reach out. Thank you, everyone.